This is a presentation systematic review on ACL reconstruction in pediatric group to assess the growth deformity and associated factors. So the aim of this study was to assess the incidence patterns and severity of growth disturbance at the tibial and femoral physis following ACL reconstruction in skeletally immature patients, and also identify the associated risk factors. So we all know that the types of ACL reconstruction in pediatrics could be three types based on how we drill the tunnel in the femoral and tibial components. It could be the transphyseal, where we do go through the physis. It can be intra-epiphyseal, which we avoid the physis there, and could be out of the physis, that is extraphyseal. So ACL ruptures in children leads to instability and meniscal damage, and reconstruction can also cause risk to the growth plate, the physeal injury. So ACL reconstruction in the unstable pediatric knee reduces the risk of further instability and secondary meniscal and articular cartilage injury. So the problem statement is conventional ACL reconstruction risk damage to the growth plates. So it can cause angular deformity when the physis is damaged at the peripheries, especially the varus and valgus deformities. If the physis is involved in the center, and if the growth arrest happens at the center of the physis, it can cause leg length discrepancies like shortening or lengthening. And reduction in the tibial slope is seen when the anterior physeal arrest is seen in tibial physis. So the question is, can physeal sparing techniques reduce complications? The objective of this study was to assess the incidence and patterns of growth disturbances in pediatric ACL reconstructions, evaluate graft failure rates, but some of the papers in our study didn't mention about graft failure rate. And also we compared outcomes across various techniques of pediatric ACLR. We followed the PRISMA guidelines. The search engines were PubMed, Scopus, and Web of Science. We had 518 articles screened. 78 articles were included. The publications were between 1994 and 2022. In total, we had 2,693 pediatric ACL reconstructions. Overall, we had 2,693 cases with mean age of 12.8 years. 68% of them was male and 31 was female. We had 70 patients with growth disturbances, and the mean age of kids with growth disturbances were 12.1 years. Again, male was around 75%. Coming to the types of growth disturbances, valgus was mostly seen with almost 26 cases out of 70, followed by varus, and limb length discrepancies like shortening and lengthening was the next. And we had very few cases where we had reduction of tibial posterior slope, probably because most of the articles didn't mention about that. When we compare the growth disturbance rate by technique, femoral intraepiphyseal techniques had the highest rate of highest rate of growth deformities, followed by transphyseal techniques. When we look into the combination of physeal, what tunnels were used in tibia and femur, the combination of tibial transphyseal and femoral intraepiphyseal showed the highest rate of growth disturbances with 3.7%, followed by intraepiphyseal tibia and femur, which showed 3.3%. We also looked into the graft failure. We found that overall risk of pediatric graft re-rupture was 7.8% in our review. However, due to limited follow-up, the true failure rate is likely to be higher over longer follow-ups. So among the tendon groups, hamstring tendon showed the highest graft failure rate, probably because we had a large number of patients who underwent ACL reconstruction with the hamstring tendons. Re-rupture rate was, as I mentioned, 7.8 Transphyseal techniques showed higher failure rates than physeal sparing. No re-ruptures with 29 allografts in our review, but in contrast to most other studies, allograft showed high rate of graft ruptures. So these were the graft rupture rate by graft type. We see the hamstring autograft almost had 9.3% of graft failures. Coming to the discussion, growth arrest in pediatric ACL reconstruction can happen in three mechanisms. One is arrest, second is a boost, and a deacceleration. So whenever there's a growth arrest, there's a physeal bridge formation. If it happens in the center, it causes limb length discrepancies like shortening or lengthening. And if it happens in the periphery, it can cause angular deformities like varus or valgus deformities. Boost is the mechanism is described by hypervascularization. Whenever the tunnel for the ACL is drilled close to the physis, it causes increased in blood flow and can stimulate the growth of the physis and lead to limb length discrepancies and angular deformities. A deacceleration is slowing of the growth plate can happen in many reasons. Some of them are like hardware fixation, use of bone plugs, large tunnels which are oblique. So what they mention is oblique tunnels can damage a large surface area of the physis, and this can lead to the growth arrest. Tenodesis effect from graft tension across the open physis has been reported based on Hutto-Workman's effect, which states that compression across the physis causes slowing of growth and distraction causes acceleration. So reduced tibial slope has been mentioned in few of the articles, which says this is mainly due to the anterior tibial physeal arrest due to biointerference screws, and this also secondly lead to graft failures. Greater volumetric femoral physeal damage has been shown to related to angular deformities. Bone plugs and hardware crossing the physis have been strongly associated with localized growth. The role of tenoepiphysiodesis by transphyseal graft was demonstrated in animal studies. So how to reduce the growth deformities, minimize the volumetric damage to the physis, keep drill size under 7 mm and drill angle steep. As I mentioned before, more angled drilling can cause more physeal damage. Avoid drilling the physeal peripheries to prevent angular deformities. Avoid inserting a bone plug, hardware, or synthetic material through the drill physis, and do not leave the drill hole empty. And during intraepiphyseal drilling, an optimal gap should be maintained between the drill bone and the physis. Excess tensioning across the physis with the intraepiphyseal graft placement should be avoided. So extraphyseal techniques are shown to have minimum growth disturbances. However, excessive graft tension should be avoided. We had some limitations in our study because most of the patients were not followed up till skeletal maturity. There's variation in methods of assessing growth disturbance, mostly clinical and plain radiographs, and not CT scan or other methods were used. Subtle angular deformities may have been missed. We had only retrospective and prospective case studies. We didn't have any randomized controlled trials, and there would have been a publication bias also. Future directions, there should be a standardized and protocol for pediatric ACL reconstructions. National ligament registries could be helpful to follow growth deformities post-pediatric reconstructions. Longer follow-up and randomized control studies into with studies going up to the skeletal maturity should be beneficial, and improved imaging and surgical navigation is necessary. To conclude, pediatric ACL reconstruction is safe. Extraphyseal techniques have lowest risk. Careful tunnel placement and graft choice is very critical. A need for registries and long-term follow-up is needed. Thank you.